Good evening to all of you that are tuning in. So my name is Dr. Gabriel Galan. I'm a board certified podiatrist with Southeast Orthopedics, where I've called my home for about 5 years now. And tonight, I think we have a really awesome presentation related to everything about bunions and everything that I think most of my patients and patients in general need to know when discussing bunions and bunion treatment and all the above. So let's just make sure our clicker is working. All right, there we go. So a little bit of background on myself. I did my undergraduate studies at Florida State University, did my podiatry medical school at Barry University in Miami, Florida, and did my surgical training in Plantation, Florida, with an emphasis in forefoot reconstruction. So I think in order to be able to get a good understanding of what we're going to be talking about tonight, we got to go over some very general anatomy of the foot. The foot is a very intricate structure composed of about 28 bones, 33 joints, 107 ligaments, 19 muscles. The 56 bones in both of your feet combined make up about a quarter of all the bones in your body. So you can imagine there's a lot of stuff going on down there. So when we're talking about bunions, we really need to dive deeper into the anatomy of the big toe. So the big toe, we refer to that as the hallux, and that's going to be a common word that we're going to hear tonight in this presentation. So the hallux is what we refer to as the big toe, and it's made up of two distinct structures, and that is the two bones. The one at the very top, the smaller bone, we refer to that as the distal phalanx, and the one right below it, it's the proximal phalanx. The hallux, or the big toe, articulates or has a joint, which is the big toe joint, with the first metatarsal. And the combination of the first metatarsal, proximal phalanx, and distal phalanx make up the big toe joint complex. We also have two small bones that lie beneath the joint, and they're kind of hard to see. And you can only really see them on x-ray, of course. These two little bones just help with the mechanics of the big toe joint overall. So then getting into the bunions themselves, by definition, a bunion, also referred to as hallux valgus, which is the medical term, is the large bump on the side of the big toe joint. This is really just more than a simple bump on the side of the big toe. It's actually a very complex deformity that causes the big toe to deviate or move laterally, meaning moving towards the smaller toes, while the first metatarsal comes out towards the inside of the foot. You then develop this prominence or this growth on the side of the big toe as a result of rubbing over the course of many years, because you have this bony prominence on the side of your foot. So when we talk about bunions, hallux valgus, the other term, this deformity develops in about 2 to 4% of the population. In the United States, we roughly perform about 200,000 bunion corrections each year, which is a lot. 46% of bunion deformities occur in the ages before 20. So it's actually a deformity that can occur at really many stages in life. Women are twice as likely to develop bunions rather than men. And some can say that this is attributed to shoe wear, of course. And then 84% of patients do develop bunions bilaterally, meaning on both sides or both feet. What's interesting is that in about 72% of patients with bunions, there is a reported familial history. So this is genetic. And then out of those people who reported a genetic history or prevalence of bunions in their family tree, 94% of them said it was occurring on their mother's side or maternal side. Sorry, we're having some technical difficulties. There we go. So now we're going to get into the causes of a bunion. So when we talk about causes, we talk about extrinsic and intrinsic. Extrinsic meaning that something outside of the foot is what's causing the bunion deformity. So the first thing we talk about is footwear. That's the one that I get a lot of questions about. So 33% of people without shoes, or people that wear shoes throughout their life, which is most of us, will develop some sort of bunion. So there's definitely a correlation. What's interesting is there was a study that showed indigenous populations that don't wear shoes throughout their life, only 2% of those individuals will develop a bunion. So there's definitely something to be said about shoes and the development of a bunion. So the other thing that was interesting is that occupation plays a role. So 17% of individuals who had a high demanding job responded and said that they developed a bunion as a result of their occupation, which was interesting. So in talking about intrinsic causes, we already discussed a little bit about hereditary or genetic predisposition. So about 58 to 88% of patients with a bunion do report some form of familial history. And then you talk about biomechanics. So that's the type of foot that we all possess. So the natural anatomy of our unique or individual foot. So this can be related to anything from flat feet or overpronation, the overall shape of the first metatarsal, hypermobility, meaning how flexible is your foot, plays a big role. And we'll get into that also in this discussion tonight. And then the length of the metatarsal also plays a pretty significant role. Some other contributing factors, like we had already mentioned, the hypermobility, which is how flexible is the joint, not only at the big toe joint, but the joint right behind it, which we call the MTC joint. So individuals who have a more flexible big toe joint are more prone to developing a bunion deformity over the course of their lifetime. And then we talk about arthritis. So arthritic changes in the big toe joint, also referred to as hallux rigidus, can play a role in the development of a bunion deformity. So here in this picture, we see how we grade arthritis in the big toe joint. You can see on the picture on the very far left, the joint is visible. You have a nice line and smooth line that goes through the joint. As we progress towards the right side of the screen, you can see that that line starts to faintly disappear. And when you get to the very last box, or grade 3, you can see that there's no joint visible and that we have a lot of spurring and a lot of destructive changes in the joint, and that's severe arthritis, which can also develop into a pretty severe bunion deformity. So talking about symptoms of a bunion. So the first thing that most of my patients will report when they come to see me in the office is, of course, pain and soreness at the big toe joint. This can also result in inflammation and redness at that site. A burning sensation or possible numbness is also very common. And this is because there is a nerve that courses right over that bump. And because you have this prominence, and if we're wearing closed-toed shoes, you're compressing that nerve, which can result in burning or numbness. We usually will notice these symptoms most commonly while wearing shoes, which most of us do pretty routinely throughout our life. So these are some of the things that most of our patients will report.
I got a question.
Sure. So patient evaluation. So what are we looking for when we see a patient that comes into the office and says that they have a bunion? Well, the first thing we do is we take x-rays. So the x-rays are really important because it's able to, we're able to get a lot of different angles and different objective findings of a bunion so that we can kind of quantify the type of severity of the actual deformity that we have present. Of course, we're going to take a very detailed history of the patient. So patient activity, shoe wear, when did the pain start, age, etc. And then the physical exam is location of pain. Is there hypermobility? Do we see arthritis? How does the patient walk? Is there any other type of pathology located in the foot, like flat feet or high arched feet, that's contributing to this deformity? And then, of course, standing position, or how the patient stands throughout the day, is also really important. When we talk about evaluating for a bunion on x-ray, we first look at these two very important angles. On the left side of the screen, we talk about what's called the intermetatarsal angle. This is the angle that's formed between the second metatarsal and the first metatarsal. So the larger that angle is, the greater the space between the first and second metatarsals. So obviously, as that angle widens, the bunion can become worse. A normal IM angle is 9. Anything greater than 9, we will say that is a form of a bunion deformity. On the right side of the screen, we have what's called a hallux valgus angle. And this is the angle that's formed between the first metatarsal and the hallux. That's like we were talking earlier about the different anatomy. It's important to kind of identify these structures. So if the larger the hallux valgus angle is, again, same kind of concept as with the IM angle, the worse the deformity is or the worse the bunion is. So this is just a table that shows what mild or normal, mild, moderate, and severe angles are for a bunion, and also the intermetatarsal angle and the hallux valgus angle. So as we mentioned earlier, the IM angle or intermetatarsal angle normal is 9, with hallux valgus angle is 15. Severe is anything greater than 20, so almost double. And same thing with the hallux valgus, 40, so more than double. Another radiographic or X-ray finding that we look at is the position of the sesamoid bones. So those are those two little bones that we had talked about previously that are located underneath the joint. What's interesting to see with a bunion deformity is that as that first metatarsal starts to sway outward, those sesamoid bones actually stay where they're meant to be. So they come out of alignment. So the worse a bunion deformity becomes, the more out of position those sesamoids become. So on the right side of the screen, on the left side of the screen where you see the X-rays, you can see the sesamoids on the very first picture are neatly underneath the first metatarsal head. Those are those two circles underneath that we see. And as we progress towards the right, those sesamoids come out of alignment, meaning the bunion is worse. The diagram on the right just shows the position of a sesamoid, how they're in line with the big toe on the left side. And on the right side, the diagram shows that as the bunion progresses, that line is completely distorted. Another angle that's important to note is what's called the hallux interphalangeal angle. And this is the angle that's formed between the distal phalanx and the proximal phalanx. And this is important because this can sometimes lead to the addition of a separate, smaller procedure when we're talking about bunion correction to be able to address this other deformity at the very tip of the toe to give the toe the best possible appearance and function, of course, most importantly. So what are some non-surgical treatment options for bunions? Well, these are all the things we're talking about in the office on our first visit. So the first thing I talk to patients is footwear. So wearing the right kind of shoe is very important. You want to choose a shoe that has a wide toe box, and we want to make sure that that shoe is a stiff-soled shoe. So the less motion there is in the shoe, the better is going to be, because we are actually protecting the bunion. And really important is the width. As you can see here on the right side of the screen, a wide toe box shoe is really important. Padding for a bunion is also really helpful. So on the bottom side of the screen, we have a variety of different bunion splints. And really all of these are designed to help position the toe in a more straight alignment, which helps reduce some of the symptoms. We'll talk about this a little bit further, but it's important to know that all of these different paddings and toe spacers are not going to get rid of the deformity. They're only going to help with symptoms, and we'll get into that a little bit later as well.
Sorry, I'm getting reports that they can't see the slide changes, so I'm trying to make sure everything's working properly.
Okay, I'm hoping that fixed the problem. We're going to move on to the next slide and see if that worked. So please report back to us if you're not seeing what I'm discussing on the screen, okay? So some more non-surgical treatment options are going to be medications like non-steroidal anti-inflammatories. These are going to be your ibuprofens, your Aleve. These medications are really just designed to help with inflammation, which are going to help with your symptoms, of course. Injection therapy, things like corticosteroid injections into the joint can certainly be helpful, especially in the setting of arthritic changes in the joint. These can be administered in the office under ultrasound guidance. I typically do them every 3 to 6 months, depending on the patient's symptoms. So that's certainly an option. And then orthotic devices. So depending on other types of foot pathology, like flat feet, we talk about orthotics to help neutralize these deforming forces, which is going to help prevent further development of a bunion long term. And then we get into splinting and bracing, like we talked about earlier. So these are different types of devices that are placed in between the first and second toes that help push out the big toe to help get a more straight alignment, which helps reduce the prominence on the side of the foot. There's also different paddings that can be put directly over the bunion itself so as to reduce the amount of rubbing on the side of the foot, and that can certainly be helpful. But none of these devices are going to be able to get rid of a bunion over time. It's not as if we're putting braces on teeth, right, that we're slowly straightening that toe. Unfortunately, it doesn't work that way. These devices are purely only designed to help with symptoms over time. There is something to be said. There are some conflicting studies that show that the continuous use of these types of devices can delay the further progression of a bunion long term, but there's a lot of conflicting data on that. So we can't say for sure. I always tell patients, if it doesn't hurt to use them because it may help over time. So then the question becomes, when is surgery needed? So I always tell patients, if it doesn't hurt, then you really shouldn't be looking to have surgery done. I think bunion surgery should be reserved for function and pain reduction, not just purely cosmetic, although cosmetic is part of the equation. So ongoing pain and discomfort, despite a period of conservative treatment under my care. Pain in closed-toed shoes, of course, if the bunion is getting worse over time. So if I'm seeing a patient back in the office over the course of several months and we see that that bunion is getting worse, that's certainly a cause to want to discuss possible surgery. And then, of course, any arthritic changes in the joint. If we see that there are arthritic changes, that might kind of push us to want to pursue surgery a little bit sooner to try and prevent any further degradation of the joint over time. So then we talk about, how do we select the right type of surgery for the right type of patient? So this very complicated table on the right side of the screen shows different factors that we take into account when deciding what kind of bunion surgery to perform. I put this really just as an example. Over the course of foot and ankle surgery, there's been over 200 to 300 different bunion surgeries that have been described in literature. So there's many, many different surgical options for bunions. This evening, we're going to talk about the 3 that I perform in my office, which I think encompass all of the different variables that are unique to each individual patient in being able to fix their bunion deformity. So there are a lot of variables that are taken into account when choosing the right type of procedure. So the 3 bunion corrections that are very commonly performed in my practice are as follows. There's 3 major ones, each with their own unique benefits. So the first is what's called a distal metatarsal osteotomy. Another name for this is a minimally invasive bunion correction. And this is a procedure that's really reserved for that mild to moderate bunion, which is the majority of the patients that are seeking bunion correction. So this is a very reliable procedure that's done through very small incisions on the side of the foot, which lead to shorter recovery times overall. Secondly, we talk about what's called a Lapidus bunionectomy. Another trendy name for this, and we're going to get into that, is what's called the Lapiplasty procedure. And this is a procedure that's performed for deformities that I reserve for a more moderate to severe bunion. I think it works a lot better for those folks. And really, this is the gold standard procedure for patients that have that hypermobile deformity. So if we see a lot of flexibility in the big toe joint, this may be a better alternative. And then lastly, we talk about the first metatarsal phalangeal joint fusion. And this is fusing the big toe joint. And really, this is the best procedure reserved for patients that have a more moderate to severe arthritic change in their big toe joint. It not only fixes the arthritic changes by fusing the joint, but it also straightens the toe and gets rid of the bunion. Another unique thing about this procedure is this is the gold standard procedure when we're addressing a failed bunion procedure. So if a patient comes into my office and they've had a previous bunion surgery that has failed, this is usually what I discuss with patients, of course, just depending on a lot of multitude of other factors. So let's get into the distal metatarsal osteotomy, or the minimally invasive bunion surgery. So again, this is a bunion correction that's reserved for that mild to moderate bunion. Usually I reserve no hypermobility, so I'm testing for that, making sure that there's no hypermobility in the big toe joint. I think in my practice, this is the one procedure that affords patients to get back on their feet the fastest. It also achieves complete correction of the deformity in all planes. So like we talked about, a bunion deformity is complex. There's many different deformities in a variety of different structures in the big toe joint, and this addresses all those factors. It is a technically challenging procedure, so I always tell patients you want to make sure that when you're choosing your surgeon, you see that they've been highly trained in this technique and that they've done a wide variety of these procedures. And it is also associated with a greater rate of recurrence. However, this has been completely disproven. The minimally invasive surgery, in fact, has the same but better outcomes as compared to other traditional bunion surgeries. So the way that this is performed is through very small incisions on the side of the foot. You can see here on the right side of the screen what a traditional bunion surgery looks like. Very large incision that's performed on the top side of the joint. You can see this measures about 3 to 4 inches, whereas compared with the minimally invasive surgery, you've only got very small incisions located right behind the bump and right behind that where we insert the screws in order to be able to hold our correction. The benefit of smaller incisions means that the less trauma that you're causing to the foot, well, the quicker the recovery is going to be. So smaller incision means faster recovery, means getting back to your normal life. So the surgical technique is as follows. You can see on the bottom side of the screen here a bunion deformity. You can see the intermetatarsal angle is increased like we talked about. The hallux valgus angle is increased. You can see the sesamoids are out of position. So all these things that are running through our minds when we're addressing a bunion. What we do is we make that small incision like we had talked about, and we use a special device, which is called a minimally invasive burr, to create a cut across the metatarsal. Once that cut is performed, we then move the head of the first metatarsal over towards the smaller toes, correcting the deformity. So we're putting those sesamoids back underneath the first metatarsal head, we're closing down the intermetatarsal angle, and we're getting that toe realigned, making it straight. Once we have that position in place, we then put 2 small screws that go across the first metatarsal, again through a small incision, that holds the correction in place. So the recovery for this type of procedure is typically 1 week non-weight bearing in what's called a posterior splint, which is a soft cast. So the first week after surgery, I usually will instruct patients to remain mainly non-weight bearing. You are able to put some weight on your heel to get up, go to the bathroom, do your normal activities like getting onto a bed or onto a couch, but that's about it. At that first week post-op visit, patients come in and we transition them into a walking boot. So in the walking boot, now patients are able to walk, do their normal in-house activities, and you're in that boot with that restriction 2 to 4 weeks. At 4 weeks, I usually will transition the patients out of the boot and into a supportive tennis shoe. The total amount of time from the day of surgery to the time you're back into a normal shoe is usually about 4 to 6 weeks. So now we get into the Lapidus or Lapiplasty bunionectomy. So again, as a refresher, this is the procedure that we reserve for patients that have a lot of hypermobility or have a more moderate to severe bunion deformity. This is actually a procedure that's been around for a very long time. It was first described in 1934 by a surgeon called Paul Lapidus. That's where the name comes from. There are many different variations of this procedure as it relates to the type of preparation of the joint, the type of fixation, meaning are we using screws, are we using plates, are we using a combination of those things? So there's been a lot of variations over the years. One of the things that has been revolutionary in my practice and overall has been a recent advancement in this procedure where a company has developed a system that makes this procedure very reproducible. And that's the Lapiplasty 3D bunion correction. So this is a procedure that uses a variety of different jigs and cutting guides and a very standard form of fixation to be able to get a very reproducible outcome. So the Lapiplasty system, or the 3D bunion correction, addresses the deformity in all three planes, meaning not only are we closing down that intermetatarsal angle, we're also rotating the metatarsal into a corrected position, getting those sesamoids back underneath the first metatarsal. The way this is performed is by fusing the joint behind the big toe joint. This is called the first tarsal metatarsal joint. You can see it pointed in the center of the screen, which is what we refer to as the actual cause of the deformity. There's some conflicting arguments behind what is the actual source of deformity or where is the center of the deformity, but certainly in hypermobile patients, this is one of the primary causes, and that's why we fuse this joint. So the way that it works is we are fusing the source of the hypermobility. So we are fusing that joint in order to restore a sense of rigidity across the big toe joint complex. So rather than in a hypermobile patient just fixing the problem at the very end of the toe, we're fixing it at the actual cause. So the technique for this procedure is a 3 to 4 centimeter incision that's performed over that first tarsal metatarsal joint. Once that incision is performed, we then have to remove the cartilage across the first tarsal metatarsal joint in order to be able to fuse it. That allows us to bring the big toe joint over, also rotating it, again, getting those sesamoids underneath the big toe. And then the way that we hold that in place while it's healing is we put 2 metal or titanium plates over the fusion site, which are then fixated with screws. So this is an X-ray that shows the before and after of what this looks like. So you can see on the left side of the screen, you've got a pretty big bunion, moderate to severe, I would grade. And then on the right side, you can see the metal plate with screws both on the top and side of that joint that's been fused. And you can see how straight that big toe joint now lies. So the recovery for this procedure requires patients to be off their foot for 2 weeks. You're usually in a posterior splint during this time, which again is a soft cast. I'll usually have patients walking on their heel during this time. One of the things that I think needs to be mentioned is that a procedure like the Lapiplasty procedure is a company that is promoting their system. So they're going to talk to patients or consumers directly, and they're going to give their own generalized source of what they think is the common recovery time. Every surgeon is different, right? So, and ultimately it's the surgeon's decision as to the recovery times for patients. I'm a bit more on the conservative side. I usually will have patients non-weight bearing for 2 weeks. Sometimes if you read the Lapiplasty website, they'll tell you that you're walking immediately, but I find that that leads to a lot of inflammation and pain long-term. And I really don't want my patients to be in a lot of pain or have their feet swollen for a long period of time. So non-weight bearing for 2 weeks, you then come into the office. We transition you into a short walking boot. You're in that boot for about 4 to 6 weeks. And then we transition you into closed-toed shoes or supported tennis shoes at about that 6-week mark. So surgery to shoe total time is about 8 to 10 weeks, give or take. Most patients can expect to return to most activities with this procedure at about the 4 to 6 month mark. And that's also very common with the minimally invasive bunionectomy as well. And when we talk about activities, we're talking about high impact activities like playing tennis, running for long periods of time, things like that. Most patients are back to their normal activity a lot sooner. And lastly, we're going to talk about the first metatarsal phalangeal joint fusion, or the big toe joint fusion. This is the gold standard for bunion deformities associated with more severe arthritic changes in the big toe joint. So if we see that there's a large bunion or even just a moderate bunion and there's a lot of arthritis in that big toe joint, I'm usually going to talk to patients about this procedure. One of the things we find is that performing a regular bunion surgery like a Lapiplasty or a minimally invasive bunion surgery on a patient that has arthritis can develop into pain after the procedure. So even though the bunion has been corrected, the arthritis is still there. So, we've done all this work, we've gone through all this recovery, the toe does look clinically better, but the patient is still in pain. So that's something to really keep in mind. If there's arthritis, we may want to consider this procedure. We'd also mentioned previously that this is the procedure reserved for those patients that have had previous bunion surgery and the bunion has come back. So the reason for that is that once you fuse the big toe joint, the chances of that bunion coming back are really zero, because you've now fixated or completely made the toe rigid so that bunion can't come back. So sometimes that's very beneficial if a patient has already gone through surgery and has arthritic changes. So the way that this procedure is performed is we make a small 3 to 4 centimeter incision overlying the big toe joint. We then identify the joint and remove all the remaining cartilage and debris, and we remove all of the spurring as a result of arthritis. Once that's performed, we place the toe in a straight position, and we then place a small metal plate or titanium plate over the fused joint to hold it in place during the healing process. In all of these cases, the hardware that we put into the foot stays in. All of this hardware is designed to stay inside the foot. It does not need to be removed. In very rare instances does this hardware cause any issues long-term that requires us to have to remove the hardware down the road. So the recovery period for a big toe joint fusion is non-weight bearing for 1 week. So again, you're in that soft cast or posterior splint. You're weight bearing in a short walking boot for about 4 to 6 weeks. We transition you into a supportive shoe at that 4 to 6 week mark. So total time between surgery and getting back into a supportive shoe is about 6 to 8 weeks. And again, most patients can expect to return to most activities like high impact activities at about that 4 to 6 month mark. One of the things that needs to be discussed when talking about the big toe joint fusion is that it's one of these things that patients believe that if their big toe joint is fused, they're not going to be able to do all the things they love to do, like running or playing golf or playing tennis. And really, a lot of that is completely untrue. I have a lot of patients that have this procedure that are very active. They love to play tennis or other activities, and they're absolutely able to get back into doing all of these things. It really does not impact a patient's ability to run or walk. It does not change your gait pattern. Once you become accustomed to the new mechanics of the big toe joint, it's very highly functional surgery. The one thing you're not able to do with this procedure is you're not able to wear high heels because you're fusing the big toe joint. So wearing high heels inevitably requires you to have to bend the toe. So that's the one thing that you're not able to do. So for my female patients, that's the one thing I always tell them. So if you're wearing high heels and you really want to wear high heels down the road, this may not be the procedure for you. So in summary, a bunion deformity is a more complex triplanar deformity. It's not just simply a bump on the side of the big toe. It's not just a growth. It's really a joint that's out of alignment, that's out of position, which is caused by a multitude of different factors like we have discussed. Bunions can be effectively treated conservatively by managing the symptoms. However, correction of the deformity will require some form of surgery, as we talked about. Choosing the correct procedure to fix a bunion is really dependent upon many different variables that are specific and unique to every patient. So those are all the things that we are getting the information from the patient in the office with x-rays, with histories, with discussions so that we can choose the best and most appropriate procedure. And then significant advancements in bunion surgery has made the correction of these deformities a lot more reliable and a lot less painful for patients overall, making this procedure a great procedure option for patients with this deformity. So thank you very much. I'm now going to open up for some questions and discussion.